Welcome to Unscripted, the AMCP podcast, a look inside managed care pharmacy. Listen in as experts explore the challenges, innovations, and opportunities shaping healthcare for millions of patients. Welcome. This episode of Unscripted, the AMCP podcast, is sponsored by AbbVie Inc. AbbVie, we find answers that make life better for patients in our world. Our guest today is Casey Koch, PharmD, Clinical Pharmacy Coordinator at Select Health. We'll be discussing IBD and some of the approaches to the clinical management and pharmaceutical management of this disease. Welcome, Casey.
Thanks, Fred. Yeah, thanks for having me. Really happy to be here.
Yeah, it's a pleasure to get you on today. So why don't we begin, Casey? Could you give us an overview of IBD?
Sure, absolutely. So really when we're talking about IBD, inflammatory bowel disease, we're primarily thinking of two conditions. It's Crohn's disease and ulcerative colitis. And then from there, we're really thinking about the severity of the disease, and that's really going to guide the treatment. So when you're in the more mild to moderate space, you're going to kind of go one way with treatments. And if you're moderate to severe, it's going to be a little bit different. And that's really the primary spot where managed care pharmacy is really interested, is in that moderate to severe patient population where we start thinking about biologics and other types of therapies.
So obviously there's been a lot of advancements. And how has our understanding of IBD changed over the past decade? And what are some of the most significant breakthroughs that we've seen in research and treatment?
Yeah, there has been quite a few changes over the last decade. There's first of all, there's a lot of new drugs. So we're thinking about different mechanisms of action, more targeted types of therapies, just a lot more options. So really 10 years ago, we only had a few options when patients were getting to that later line of therapy. Whereas today, you have, and it's a nice problem to have, but we have different mechanisms of action, different drugs that can be used. And we're also starting to think about different targets. So I know we're going to get into it, but we're thinking about not only that the patient is symptomatically better, but also that we can see objectively that the patient has responded to therapy.
Mm-hmm. So obviously with all these options, as with other disease states, we see current guidelines, treatment guidelines out. So what are the current treatment guidelines?
Yeah, so we are seeing more rapid updates now, which is actually a great thing to have as well because of so many of the advancements. So I'm primarily looking at kind of two bodies of guidelines, so the ACG and the AGA. And the most recent updates really have been even in the last 6 months to a year. And the AGA has stated they're going to update at least every 6 months, or at least re-review every 6 months as the landscape continues to change so rapidly. So this is a disease state where we can actually have modern guidelines that incorporate new therapies as they come out. Whereas in a lot of other therapies, you might have dated guidelines and kind of left out in the open with what to do with the new drugs that haven't yet been reviewed.
So when you look at these guidelines, sort of how are they looking at treatment and the approach? Are they stepped or things like that?
Yeah, absolutely. So I think we're seeing some new guideline recommendations. So there is a thought to sort of treat earlier with biologic therapies. So we're thinking about more, so let's say the AGA guidelines have put therapies into more buckets now of how efficacious they are. So they're not necessarily thinking about mechanism of action as much. So it's more about highly efficacious, moderately efficacious, or lower efficacy. And then from there, because there are so many options, it opens up more choices for patients.
And when we think about that in choices, what are some of the unmet needs we're dealing with now?
Yeah, there's definitely still unmet needs. So I think we've seen a lot of advancement. Patients are doing better with so many options, but there are still unmet needs. So I think we're still missing areas where we can personalize the therapy, have a better idea of whether or not a patient's going to respond. We also have unmet needs in particular in that late line setting. So if patients have exhausted a lot of the options, we really don't have kind of a last line therapy. So what we've seen in that spot is a lot of dose escalation. And so that's been something where your providers are going off label for more frequent dosing and in the hopes to get patients back into remission.
And when we think of these and these newer approaches and technologies, you just mentioned personalized care. Are we getting close there? And how about the use of biomarkers and other things such as targeted treatment?
I think we're still a ways away, as we are in a lot of therapeutic areas. We are seeing some kind of algorithms to try and determine whether or not a patient would be a better responder to certain therapy over another. We're definitely using lab values to guide therapy. And I am seeing more and more drug levels being used. So if a patient maybe only having a partial response or not responding to a drug, providers can pull actual drug levels from the patient and determine if maybe they're an ultra rapid metabolizer and the drug is getting removed from the body too quickly. And that's another spot where we do see the dose escalation as well.
So it sounds like this is fairly complex. Is it really something as you're getting the data in and looking at it from your angle or side, you're trying to, in essence, assist the physicians or providers with that care? Or how does that sort of work?
Yeah, I think ideally the payer is more hands-off. I mean, we definitely want providers to be able to assess their patients, make choices on which therapy to use and guide that therapy with the clinical presentation that they're seeing. I think we've been, with how many therapies we have now, we have more options to be able to do that. We've seen launch of low-cost biosimilars, and that also gives additional options for providers and patients. And I think the best thing that we can do moving forward is to just give additional options.
And when you're looking at that, what do you consider as a positive outcome? I know that there's a range, and as you say, some people are further along, require higher doses and things like that. But what do you look for as a positive outcome?
Yeah, absolutely. So in clinical trial setting, we are generally looking at clinical response, clinical remission, and some of the newer therapies are also now looking at endoscopic response and remission. So that would be more of an objective marker, whereas the clinical response or remission would be more symptomatic. In practice, we are seeing both coming in when we view chart notes. I know providers are looking at lab values. They're also looking at just patient attestation of how they're doing, but they're also looking at the response on the scope. So really, I think it's a totality of all of that in terms of what an actual good response looks like. But if you get a patient that's into remission on a drug, that's a great spot to be in. And then another part that's really coming up, and it's kind of going back to the unmet need, is when can a patient come off of therapy? So if a patient is in remission, they're doing well, we don't have a lot of data on feasibility of a patient coming off, maintaining their response long term.
And do we have a sense of, as patients consider this, how many might be achieving remission yet?
Yeah, we do. I think that's kind of come out of the clinical trial setting. We are seeing pretty impressive rates, and it sort of depends on a number of factors. So, what's the disease presentation? Is it mild, moderate, or severe? What therapies has the patient already attempted? So the more therapies a patient has attempted, we're generally seeing that they're less likely to respond to additional therapies, which kind of goes back to that initial top-down approach where we want to really find a therapy that works early on for a patient, get them lasting remission that can last long-term for them while still having additional options if they have a relapse.
And in terms of remission, are we seeing longer periods of time with that when we consider that, or where are we in understanding that?
Yeah, I don't know that we really know for sure on that. In clinical trials, we're generally going out to a year, seeing maintain responses in a lot of cases. Historically, a certain amount of patients are going to fall off every year, whether it be to just loss of efficacy. There's also issues potentially with non-adherence or other problems that can arise. So I do think that we have drugs that have long remission periods, but I don't know that we have a great cross comparison to know that certain drugs do actually last longer than others.
And this episode is sponsored by AbbVie Inc. Our guest is Casey Koch. So Casey, as you look at a pipeline of new products, what do you see as the most promising therapies, and how might that change the standard of care?
Yeah, so I think we are sort of seeing some of the pipeline come to fruition right now. So we have a number of new products in the last year or two in IBD, both Crohn's and ulcerative colitis. Primarily we have 3 IL-23 inhibitors now that are approved in one and or the other. JAK inhibitors are coming out. We also have S1P receptor modulators. So we have new mechanisms that I think are still getting fully fleshed out in the real world on use, what kind of responses we're going to see. And I think it's maybe a little too soon to tell until we really get a lot of real world utilization on how patients are ultimately going to respond.
So, Casey, obviously fairly complex issue. How do health plans or PBMs take a look at this and consider it from a pharmacy management approach?
Yeah, I think that's a great question. So we have an extremely complex area of pharmacy management. We really can't think about IBD without also thinking about rheumatology and dermatology because there's so much overlap in the indications of the products and the use. And so really, I think an ideal way of managing this offers coverage for not only IBD, but also those other disease states and gives a significant amount of offering. I'd mentioned earlier that some of the thinking is moving away from mechanism of action in IBD and more towards the level of efficaciousness of the product. In those other areas, it's still more mechanism of action focused. So we really feel like we have to have an offering that spans the mechanisms of action while still giving adequate options to providers and patients.
And so does that mean you're really looking at sort of more broadly allowing for these various agents so providers are able to have choices and mix and match things to try and deal with solving the IBD issue?
Yes, it does. And I think that's probably what you're going to see at most health plans is some sort of offering that may or may not be specific to the actual disease state, but still keeps the disease state in mind so that you're still offering adequate coverage, enough options for patients, and all those sorts of things. Another thing that's going to come up, and it's starting to happen now, is I mentioned the biosimilars that have come out. So we are seeing, we now have 2 TNF inhibitors that are a biosimilar availability. We're going to have an IL-12/23 starting essentially now. So you'll start to see some availability of biosimilars in that space. And that really is going to be the thought moving forward is if we have some low cost options that are still guideline recommended, how do we, from a population health standpoint, get those therapies to the right patients while still then offering some additional therapies for the patients that those may not be appropriate for.
Mm-hmm. And you mentioned this a little bit earlier, getting in a little earlier, starting a little earlier, and there's some talk of a top-down approach. How might that look to health plans?
Yeah, so I think historically we've seen more of a step-up approach, which would be using maybe some small molecule products, see if there's a response from the patient. If there's not over time, then maybe starting sort of a later line of therapy with either a biologic or a specialty medication. Some of the thinking now has flipped that. So we're thinking that maybe early on, if you're able to get a patient on a more effective biologic or specialty therapy, then you will not see the downstream relapse of the disease. So that's the difference in the thinking. I do think that, especially with those low-cost biosimilars, we've got, even from a population health standpoint, I think we've got some cost-effective options to where that becomes a much more, satisfactory way of treating patients. And you can get treatment on early and hopefully prevent things like surgeries and hospitalizations down the road.
Yeah, and you mentioned earlier real-world evidence, and we think about that. We run the clinical trial. It's got a period of time. You get the results, but then it's put out there and we see it for a while. So are you beginning to look at those kinds of data sets more? And if so, what evidence might you be looking for bringing in this real-world evidence?
We are. And when we look at our own data, a lot of it is just utilization of the drugs. So are patients adherent to medication? We do track things like hospitalizations and those pieces, when they do come out in like a publication with real world evidence, can really play in. And especially as we're thinking about the cost of the drug, in a lot of cases was maybe more expensive than something like a surgery in the past. But if we have lower cost options now, that script can kind of flip, and the drugs may be able to be cost effective if they're able to prevent things like hospitalizations and surgeries. So I think we're going to be looking towards publications of real world evidence to show that actually is the case. And I think that really pushes towards using more of a top-down approach and getting biologics on board early.
And it sounds like health plans in general are looking at the utilization data downstream as these products are used to begin to get a sense of how it's impacting their populations.
Yes, absolutely. So I think the drugs themselves, you really are going to have a focus on the utilization of the actual drug. But yes, you can look downstream, see the effects, see if patients are able to maintain on the drug. I think that's a good sign by itself. If the patient stays on the drug long term, we can sort of assume they're doing fairly well, or they wouldn't still be taking the drug.
And one of the issues we've faced quite a bit is this issue of health disparities. And can you discuss that in this area of IBD and how that might be addressed?
Yeah. So I think something I haven't mentioned yet is primary population for this is kind of the young adult. So we probably do have some disparities in the data in the pediatric setting and really in the geriatric setting. So those are areas that have probably not been studied as much as we ideally would like. Therapies are still being used in those patient populations. We maybe don't have quite the level of data and rigor of the clinical trials to know the exact outcomes. Another spot that is rural health. So a lot of these therapies are IV administrations or have an IV loading dose. So patients do need to get into some sort of site of service to receive that dose. And that can be really burdensome for a patient that does not live near a center. The infusions themselves take time, and so be an entire day of its life to go get the drug administered. So those are some areas of kind of the social determinants of health that we've been thinking about.
So things like access, availability, et cetera, are the ones you're most focused on.
Yeah, and if you're thinking from a formulary standpoint, it kind of lends itself to having more options. So if you're thinking an IV therapy might be the best drug for a patient, but they can't get in to use it, and a provider would rather use either a self-injectable or an oral product. Making an allowance for that, I think, is something that can help with the health disparities.
Well, thanks so much, Casey, for joining us today on Unscripted, the AMCP podcast, and sharing your expertise.
Thanks, Fred. Appreciate it.
And thank you for listening to this episode of Unscripted, the AMCP podcast. This episode was sponsored by AbbVie Inc. For more information about AbbVie, go to abbvie.com.